I started in this business as a psychologist, as something called an industrial psychologist. So I worked with corporate executives when they got off track. Spent about 25 years doing that. It was very interesting, and then retired and opened a small private practice as a real psychologist. Got involved with medical aid and dying here in Washington State and volunteered as a VCA for 10 years. And then over the last couple of years, I've been doing these psychiatric or psychological assessments. So you know that we've expanded this with the new law, which is great. The specifics about how do we do the assessment, I just want to give you a couple of thoughts that I have when I go into these. Some of you may remember the TV show called Columbo, where the guy had a ruffled raincoat, and he kind of talked to people who scratched his head, didn't really know what was going on, and self-effacing. And that's kind of the role model that I take when I start to interview family members and caregivers and the patients in this process. It's an intimidating process if you think about it. I had one client who said, "I'm not sure I'm going to pass your test, Dr. Moore." And that just gives you a flavor of how they're thinking about this, because it's the last hurdle for a number of these folks to be able to become eligible. And as we talk a little bit later here, I'll give you an example or two of real patients in this. Okay, Jess. Yeah. So the diagnosis does not preclude access to MAID. Either the attending provider or consulting provider can request the evaluation if that person's concerned about the ability to make informed medical decisions. So what we're testing for is capacity here. The bullets that you can see there are the folks that are now eligible to do this. And the question that we're trying to answer is, does the psychological or cognitive functioning of this client prohibit them from making a sound medical decision? And I didn't know this, but yeah, 2.7% of people had the assessment. I don't know how many providers we have in the state at this point. Looked like about 15 or so, Jess, is that right?
I think we actually have 60 providers that have written more or less every year. There's about 60.
Oh, okay, great. Next slide, please.
I think the main point on that last is just that, you know, the number of psychiatric evaluations is very low every year in the data we look at that. And, you know, it's very few cases that we even have a question about, you know, whether or not this person does have capacity. Most cases, either the AP or the CP is very easily determining that, yes, they do. Well, both the AP and the CP are determining that, yes, they do have the legal definition of capacity for this. So it's not common that people need a psychiatric evaluation, but it does, of course, occur.
This gives you some sense politically of where the organizations are. American Psych Association is neutral. Washington State is supportive, which is great. And the State Medical Association just recently took a neutral stance, which is a great victory. So here are the components of the standard of for capacity to consent. Expressing a choice, to the aware of the choices they have, understanding what goes into this law and what happens. Do they appreciate the impact and the effect? Are they able to reason effectively? And part of that is the longevity of the amount of time they've held this particular point of view and been aware of medical aid and dying. And are they making a rational choice in their decision making? So straightforward here. This is said in different language about understanding relevant information. I was asked to evaluate a patient in an assisted living facility at one point, and went in and began talking with him. It was clear that he was quite limited. And so I asked basic questions like, who's the president of the United States, and who am I, and where are you, and what day is it? And he just had no understanding of any of those fundamental questions. So that was a relatively easy assessment to make. He was not eligible because he did not understand any relevant information to make the decision. Appreciation of the consequences of the options. Normally there's a question I ask about what other choices have you considered in this? And I would expect usually at least one or two other options that they've considered, such as BSED or no further treatment. The underlying set of values to provide guidance in making this decision. This is really about autonomy, choice, quality of life, impact on family. Any of that kind of language is clear that they've given a lot of thought to how it fits with how they've lived in their lifetime and what they believe to be true in terms of value set. And then obviously I would hope at some point they're able to communicate the decision and explain how they got to the point they are in asking for it. So do they understand? Oh, thanks.
Sorry.
Yeah, I think we've covered that. Thanks.
Yeah.
When I start an assessment, I assume capacity and autonomy, the will of the patient informed circumstances and consequences, and the value set. I sort of start with the glass half full, and if people erode these bullets here, their score kind of begins to drop as we go along. Capacity is a matter of degree. Want to pay attention to what the patient decides. And part of that is, when am I having the conversation with the patient? Because as you know, if I catch them, for example, just as they've taken their morphine or whatever medication they're taking for pain, or just as they're ready to take it, their cognitive thinking can be directly affected by that. What medications they're taking makes a difference too, in terms of their ability to be cogent. Sundowning, you know about Alzheimer's disease, and it really depends on sleep deprivation or their nap schedule too. I try to get them at their best moment, not their worst. So that I coordinate with their caregivers in terms of when we do the interview itself, and background information about the medications. Okay. So here's the process I use of the assessment. If there's any language barrier, we use a professional interpreter service. And one thing I don't do is ask the family to interpret, because they're gonna show you the best side of everything, and I'm not suspicious by nature, but it may not be the full truth. The first people that I interview are the attending provider or the consulting provider, specifically the physician or the medical person who has concerns about this patient. And I get a real good sense in that interview about what they're concerned about, what's the evidence that they've seen, how did this come to their attention, what are they worried about specifically, because that allows me to go in then in my other conversations with folks and check those out, because that's the really important concern that we have. And then I identify the key people who are knowledgeable about the patient and find out their contact information. Now, so the key people for me are family members, caregivers, hospice nurses, obviously the attending provider or the consulting provider. And if that group is, if I can't get to many of those folks, then I also will interview friends, long-term friends of the family who have known these folks. And here's some of the key questions I ask. But by the way, there's confidentiality in this, and we don't use written permission at this point, which is I'm glad of, and I really hope we never get to that point. The families and the patients are eager to have this conversation because they're aware that there is some question about capacity. And I spend probably 10 minutes with each person, getting to know them, building a relationship, finding out about their concerns before we start this list of questions. So I want them to feel comfortable with me as a person, and that increases the honesty that they're likely to deliver. So straightforward, how long have you known the patient prior to the illness? How clear thinking was the patient? How long has it been going on in terms of that level of capacity? I want to know if there's been a change recently in her mental competency, and then find out what the change looks like. How long has the patient been considering thinking about medical aid in dying? And then obviously, in your estimation, does the patient have the ability to make medical decisions? I'm not sure whether the next slide talks about the questions I asked the patient, but this is very, yeah, okay, good. This is then with the patient. So I've interviewed everybody else, and then the final person I interview is the patient, because I feel like I've then got some history and some information to work with. Again, I build a relationship with this person about early years, and we fun times, and I ask them about favorite hobbies and past work, and get a real sense of sort of who that person was in their better years. And then jump into the assessment of the illness itself. I want to find out if they actually understand what's going on with their body in terms of the treatment options, benefits, risks, diagnosis itself, and the prognosis. I asked them about medical aid in dying. When did they begin to consider this? Most of the folks that I've talked to have spent at least a year thinking about these options. And once they get to the 6-month terminal diagnosis stage, they get very serious about that thinking. How did you reach a decision regarding wanting the option to medical aid in dying? This really gives me insight into their capacity to think in a logical way. I don't want to hear things. I'd get nervous if I hear things like, my wife told me it's a good choice. Or my brother did it and told me I should do it. I want to have more independent decision-making in terms of that thinking. Again, what other options have you considered? And who have you included in the decision process? Sometimes, as I said earlier with that particular case, I have to evaluate decision capacity in a much more elemental way. When that happens, it's likely that the person is not going to be eligible if I have to be that basic. We talk about other palliative options that they may have considered and why they've rejected them or kept them. I had a guy once who had a robe on his lap in a wheelchair, and I was in his home. I asked him that question, and he pulled back the robe, and he had a .45 pistol. He said, "This is my option." Now that was interesting. Luckily, I was born and raised on a farm, so firearms don't particularly scare me. But this is a guy who had really given a lot of thought to this, and he was worried about. He said, "I'm going to fail this psych test that you're giving me," but he had his backup. Luckily, we didn't have to go that route. I've had a couple of patients who have had prior suicide attempts, and I want to find out what those were about. The basic clinical distinction that we make here is the difference between situational depression and clinical depression. Clinical depression is biochemical in its nature, long-standing, long time, usually for people that most of their lifetime they've been struggling with it. And it will it will affect somebody's capacity to think clearly. Situational depression is more appropriate, and we see it a lot with medical aid and dying patients because they've just gotten a 6-month terminal illness. And it's appropriate to be sad about that. It's appropriate to feel loss about that. It's appropriate to feel the anxiety of dying well. But all of those feelings and emotions that are considered to be negative with situational depression do not affect the capacity to make the decision. So that is the differential diagnosis that's really key in this whole process. Is after I found out all of the other bullets above, I really looked very, very closely at the kind of depression that they have, and I evaluate the suicide attempts. One favorite story I have about this is a patient who had done a female suicide attempt 3 years earlier than that. She was what I think is, I don't know whether we call them that anymore, but an alpha woman. She was absolutely crystal clear in her thinking, as assertive and actually a little bit more than assertive as anybody I've ever met in a long time. And she told me just very frankly that she'd not been able to walk anymore 3 years prior to that. Her illness had affected her ability, her capacity to move. She was the head of a very, very large dairy farming operation and had been used all of her life to be able to physically do what she wanted and manage that farm. And she said, and it was absolutely perfectly logical. And she said to me, it made no sense for me to continue living at that point if I couldn't do what it was that I wanted to do in terms of my career. There was nothing maudlin about her statement. It was kind of the most logical, rational description of a suicide attempt that I've ever heard. Absolutely no hysteria, and no faulty thinking in her profile. I checked freedom from external pressure, people being coerced or not, and then I asked the final open-ended question of what else should I consider from the patient's point of view. Okay, next slide. So then what I do is I integrate all this information, write the report. There's a summary of the conversations in my evaluation. I try to make it as user-friendly as possible because this goes to the attending physician and provider, and it goes also to the state. It's filed in the state. And so what I'm thinking about this is that if I'm somebody reviewing this in the State Department of Health, I want them to be clear, crystal clear in my evaluation. And so I don't use academic psychology language. Those of you all of you have academic backgrounds, you know what I'm talking about this. You can put something in a language that nobody outside your field understands. And I just don't do that. I try to be as, Jess, you can attest to this or not, depending, but I just try to be as simple and straightforward. And report the factors that provide the evidence that the patient currently has or does not have the capacity to make the decision about MAID. And we submit it to the AP, obviously, and I guess it goes to the DOH in terms of that format.
I'll just kind of say here that, obviously you are submitting your report to the AP. If you say that somebody lacks decision-making capacity, typically that's going to just stop the process there, in which case the prescription won't be written and the forms won't actually go to the DOH, because the only time the DOH actually wants forms is once a prescription is written. So really this psych evaluation, if it's requested, is kind of the make or break, obviously, of the case. And if the person assessing them says that they think that they lack the capacity, typically, and I've only ever seen it, one way, in that the AP will stop the process there and say, I'm so sorry, we can't proceed. So really only the forms that the DOH sees, because they are only the ones that have said, yes, somebody does have capacity and the process has gone on from there. So I've always really appreciated, Dwight, how you have, like you said, been very kind of simple in your language, very clear about, how you assessed and what were the factors that led you to believe that they did have the capacity. So it was just very clear that, that was what was found. So appreciate that.
Thank you. There's one other piece here is I get back to whichever provider had originally raised the concerns. I try to make a personal phone call to that person and talk them through what I learned and why, because they have the right to be reassured about the decision, the judgment that I made on this. And so far, it's worked out very well. People understand it. They were right in raising the flag, and we did the right thing about that patient and found out that they either did or did not have the capacity.
Well, Dwight, sorry, may I interrupt? Shannon speaking. Do you share your findings with the family and the client and if so, at what stage? Or do you allow, or do you just do the usual consulting thing where you tell the primary doc and he gets back to the family and the client?
Yeah, good question, Shannon. I do two things there. I give the information to the AP and assume that she or he will get back. And I also talk to the VCA. VCA is part of this, my interview process, and I ask them to give the results to the family. I like doing it that way because it strengthens that relationship with the VCA.
Okay, thank you.
Okay, so we have structured this now for this last section to be about some scenarios. We hope for these to be interactive. We'll kind of go through the scenario and then have some questions that hopefully people will feel comfortable to jump in and discuss this in an open format. So Dwight, I'll let you go ahead and read that.
Yeah, so take a read of this scenario.
So this is a patient, a very common scenario. I think many people we have, we encounter in this work have an element or more of depression, anxiety, and that kind of goes hand in hand with their terminal illness. So this is a very common scenario that we have, and I think it's good to address this. So let's just start out with the questions that are listed. If anyone wants to jump in, please feel free. But, should this patient be compelled with their history of severe depression and anxiety, which she herself admits is not well controlled? She should be compelled to do treatments before she can proceed with the process of certification for medical aid in dying. Anyone have any thoughts on that?
I want to add something here, if you don't mind, Jess.
Sure, yeah.
I had a chance when I was doing my PhD to do an internship for the National Suicide Hotline. And it was great training. And then I don't know, luckily I got a 6-month assignment for the night shift on that hotline. And so I have lots of experience trying to talk down people who are wildly depressed, severely depressed and anxious. And the one thing I've learned about this is that there's a 180-degree difference between most people who are considering medical aid in dying and a depressed suicidal patient. The suicide patient is erratic in their thinking. There's a degree of hysteria. The thinking process is totally inaccurate. They're grandiose in their thinking, or they exaggerate everything. Nobody will ever love me again. I'm never going to feel like I used to feel. Although this inaccurate set of thinking, there's a suddenness and erratic set of behaviors in folks who are at that stage in dealing with that kind of depression, suicidal thoughts. And most of us have experience with a medical aid and dying patient who are relatively calm, and they're serene about these decisions, and they are clear thinking about their options. So I have a bias in that you don't compel anybody to get mental health therapy. I have hospitalized patients in the past because of mental health issues, but anyway, I have a bias about that.
So yeah, and it's more than just a bias on your end, Dwight. This is actually a legal standard that the right to refuse treatment is a legal and ethical principle in the United States that allows a competent adult to decline unwanted medical intervention. So that is across the board, whether it's chemotherapy or treatment for depression. People are not able to be compelled, as long as they're found to be mental, have capacity intact. They're not compelled to accept treatments for these, even if they have an untreated condition. So yeah, this is something the Supreme Court has recognized, and it is just a legal standard. So just because someone has admittedly uncontrolled depression, anxiety, it should never be compelling to say that, oh, they have to get this treated before we can assess them for medical aid and dying. Really, those two things don't have to do with each other. People can have uncontrolled depression, and as long as they're still, as Dwight has kind of touched on here, as long as they're thinking logically, as long as they're meeting that decision-making capacity definition, then they can proceed with the process, even if they have uncontrolled psychiatric illness of any kind, really. And I think, Dwight had talked about this before, the definitions of situation versus, clinical or pathologic depression, where most people with a terminal illness that are suffering greatly have appropriate sadness and situational depression or situational anxiety. And that would actually be very appropriate and logical. And we might think it would be weirder if they didn't have that. So it's very, very common. The clinical depression or the pathologic depression or anxiety, causes that clouding in their ability to think clearly, a clouding of their logic, and affects their ability to make decisions. And that's really what we're looking for is, are they thinking logically? Are they meeting that standard? Are they able to communicate how they came to this decision? And there's admittedly some amount of subjectivity, right? Because I think whether we consider, somebody wanting to end their life prematurely via medications a logical and acceptable response to their illness, I think that we have to admit that there is a bit of subjectivity, and some providers might look at that and say, no, that doesn't make any sense to them. But I think most people can understand, even if they may not personally agree with that or want that for themselves, they can understand why someone in that position would make that choice or would want to make that choice. So let's go on to the second one. Here's another scenario of a man who's on hospice. He has kind of multiple things that have led him to have a hospice qualification: end-stage liver, COPD, heart failure, kind of a smattering of a lot of chronic conditions, severe back pain. He has an underlying psychiatric disorder, bipolar 2, and he's had 2 prior suicide attempts. And the most recent has now been a couple of years ago. So because of his history of suicide attempts, the attending provider on this case decided that they wanted to have a psychiatric assessment, just as a kind of triple check of an independent person looking and making sure that he was qualified to move ahead. So the questions for this case is, what do we do with someone who has this prior history of suicide attempts? How can they be eligible? And how can we assess his thought process now versus his prior suicide attempts? So I think, Dwight, do you want to touch on those questions? I think about, especially that second one of how can we assess the thought process in regards to MAID versus the prior suicide attempts?
Yeah, we know that cognition changes over time, that health changes over time, that somebody's the acuity of their own thinking process can decline as they get older, and certainly as they get more ill. So I don't think it's really relevant to have about a 2-year-old suicide attempt for today. I think what we assess is what the capacity is today. And that's relevant. And if the decline is such that they don't understand the law or don't understand the outcome, and then they're not shouldn't be eligible. So that would be my reaction to that second bullet.
Yeah, and I think, in fact, I just saw a patient today with this scenario where, people have this terminal diagnosis, they have some degree of suffering, which they find to be unacceptable, and they seek to end their life on their own, and it doesn't work. So today, for example, I saw a patient on hospice who was just wanting to be done, took all of his PRN, morphine, and Haldol medications, and didn't die from it, just got very sleepy and high, and then, went on. His hospice team, unfortunately, at that point, they cut him off from any PRN pain medications, which I felt was really unfair for him, this poor man who is suffering, and they kept him just on patches for pain and no breakthrough, with their concern that he was going to try to die. And of course, he's trying to die. He's going to die. He's on hospice. And he was actively trying to get medical aid in dying, but it's just been, as many people unfortunately experience, this convoluted and complicated process. He was enrolled with Providence Hospice, so he wasn't getting a lot of information and getting a lot of runaround. And so he's been trying for a long time to access this legal way to die and was getting nowhere. And so he kind of tried to take things in his own hands. This seemed very logical to me. This did not, he was very clear thinking. He was able to, he's been thinking about this for a long time. He talked about, what things about are leading him to want to make this decision. And so, just because someone has had a suicide attempt doesn't mean we shouldn't help them to die when they're qualified, right? It's illogical to actually not help them in those cases. So comes up more often than I would wish it did, but because the process can be so difficult to access for some people, sometimes they do try on their own, to end their life with whatever means they have available. So hopefully that doesn't. Go ahead, Shannon.
Sorry.
Yeah, no, please.
Dwight, just taking you back, I've heard you a couple of times in your assessment of capacity, you're using the phrase, do they understand the law? And I'm not sure what you mean by that, because that would be a different set of questions than do they understand what they're doing and the implications, and are they uncoerced, et cetera, et cetera. Will you say more about what understand the law means to you when you use that phrase?
Yeah, it has 2 or 3 components to me. One is that you need to have a 6-month terminal diagnosis to be eligible. That when you take the medication, that you will go into a coma within 6 minutes and you will die within 2 hours. I want people to be sure they understand that. That it requires the sign off of 2 medical providers to become eligible for the law.
Mm-hmm.
So those are the 3 main components I want to be sure people understand.
Thank you very much. That's helpful.
Shannon, I think that's a really good question. As we all know, people come with varying levels of understanding or knowledge, pre-existing knowledge. Now, by the time they come to this psychiatric assessment, they've almost always had both the AP visit and the CP visit. So they should have already had 2 run-throughs of all of those things, the elements of how it works, all the elements of just, informed decision-making discussion. And so, yeah, I think it's fair for Dwight at that point to say, okay, tell me what your understanding of how this works is. They should have already heard it at least once, probably twice by then. And so at that point, you're assessing their understanding. You're also assessing their retention of that information because it's something that they should have already heard. Now, I'll say when we first start this process, and do that first visit, people come with varying levels of understanding or knowledge of what the law actually is and how it works. And so that's our job as those providers to kind of go through that with them. But I agree with Dwight that by the time they get to him, they really should have some level of understanding and ability to kind of say that. Now, they may not have every little thing right. They may not be able to say, 6 minutes or 2 hours. They might just say, I know I'll fall asleep and die. but they have at least a general understanding of what's to be expected and how it works.
Yeah, thank you both.
Okay, so let's go on to our third scenario here. So this is another one that we get not infrequently, of a patient who has Parkinson's disease and has, a diagnosed mild to moderate cognitive impairment from that, but also has severe COPD on oxygen, and her pulmonologist has declared that she has 6 months or less to die, and so she is now enrolled with hospice. And she has decided that rather than going through and dying of her underlying lung disease, she would like the option of medical aid in dying. She's a long-term supporter of this. She was really proud that she had voted to make it legal back in 2008. So it's something that she's been aware of for a long time. And when she gets to the consulting provider assessment, the CP was concerned about her level of cognitive impairment, and so requested the psychiatric evaluation. So just to clarify, it's very common that we get people with whatever chronic disease or acute or chronic disease that also have some cognitive impairment. Now, obviously, if someone is on hospice because of, if the underlying hospice qualifying diagnosis is dementia, almost invariably by the time they qualify for hospice with that diagnosis, they're beyond the point of capacity, almost by definition. So this is really that time when the MAID or hospice qualifying diagnosis is something other than their cognitive impairment issues, but they have a coexisting cognitive impairment. So not uncommon, but I do want to make that distinction that we're not assessing people who are on hospice with the diagnosis of whatever kind of dementia, because those people really are almost by definition beyond the point of being able to make an informed decision. So in this case, what we're questioning is, how would we assess the patient's cognition and capacity in regards to the decision to pursue medical aid in dying? Do you want to touch on that, Dwight?
I have not had a case like this, but I think one of the things I think about doing is to try to talk to the neurologist who has described mild to moderate cognitive impairment, because there's a lot of wiggle room inside mild to moderate. If you're mild, you probably do understand or have the capacity to understand what's going on. If you're moderate, probably not. Again, depending on other factors. So I'd like to get the viewpoint of the neurologist, who's sort of a neutral party in that process. And then I would ask exactly the same series of questions that I ask everybody, and really pay a lot of attention to their capacity to answer those questions.
And I think this is a case where, for me, and Dwight, please feel free to correct me if you think differently, but this is a person who's on oxygen, so making sure that we get, like you have said, coordinating with their caregiver or whoever's with them, that their oxygen levels are at optimal levels for being interviewed, so that's not a factor in their cognitive status when you're assessing them. Obviously time of day, medications, all of that, trying to time it so that you're getting the best picture of them and what their true capacity is. And I think, one thing that's kind of favorable, I think, in this case, is the fact that this has been a long-standing, knowledge and desire from this patient, that this is not just something that's come about at the last moment. She's been known about this law and supportive of it, and wanted to consider having that option for a very long time. So I think, obviously, if she truly does have moderate or severe cognitive impairment, we still can't proceed, but I do think that helps us know that this is, there is some underlying longevity in the thought process here. I agree, Dwight, whoever made that diagnosis of mild to moderate cognitive impairment, trying to see how they assess that. You could potentially think at this point of someone like this of giving them one of those cognitive tests, one of the validated cognitive tests that are out there. They're all variable in their validation and their sensitivity, specificity, but I do think, there are many people with mild, even potentially moderate, but especially mild cognitive impairment, who still do have intact decision-making capacity. And so we don't want to rob them of that just because they have that as a diagnosis listed, or a diagnosis that they truly do have. All right, so those are our 3 scenarios.